Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS, and in this podcast, you'll hear from a diverse representation within our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. I want to welcome my co-host today, Dr. Daniel Lenahan. Dan is the founder, past president, and current executive consultant for ICOS. And it's always great to have Dan part of these episodes. Dan, thanks for joining us.
Thanks, Steve. I always love to hear about all the great efforts around the world. Today will be another interesting episode in cardio-oncology.
Yeah, and one of the exciting things that's happened over the last couple of years in our organization is the formation of specialized working groups. And today we have the opportunity to hear from the co-chairs of our exercise work group. So we're glad to have with us Dr. Erin Howden. Erin is head of the Human Integrative Physiology Lab and the co-lead of the Physical Activity Program at Baker Heart and Diabetes Institute in Melbourne, Australia. So Erin, thanks for staying up late and joining us.
Oh, it's great to be here. Thanks for the invitation.
And Dr. Scott Adams is the other co-chair of this working group. Dr. Adams is an assistant scientist at Toronto General Research Hospital and Research Institute, and he is the exercise lead at the Ted Rogers Cardiotoxicity Prevention Program in Toronto, Canada. Scott, thanks for joining us.
Great to be here. Thank you all for having.
Well, one of the things that we always enjoy doing as part of this program is we love to hear sort of a little bit about each of your backgrounds. And so I'd love to hear sort of how you got to where you are, what are some of your current interests, how you developed your interest in cardio-oncology in particular, and then love to hear from each of you how you developed your interest in exercise as a therapeutic agent. So, Erin, tell us a little bit about your background.
Sure. Thanks, Steve. So my background is that I'm an exercise physiologist. I completed a PhD back in 2012 at the University of Queensland in chronic kidney disease, where we're trying to prevent cardiac dysfunction with exercise and lifestyle interventions. After I wrapped up my PhD, I was lucky enough to spend 4 years in Texas at the Institute for Exercise and Environmental Medicine in Ben Levine's lab. And here I was involved in conducting some really incredible exercise training studies where we took people who are at risk for heart failure and trained them for 2 years, trained them with high-intensity interval training, and we looked at how this affected their cardiac compliance, so the stiffness of their heart. And these studies were really transformational in showing that exercise, if it could be adhered to, could actually prevent age-related cardiac stiffening occurring. And this is really important for heart failure prevention, especially heart failure with preserved ejection fraction. Following on from my postdoc training in the US, I moved back to Australia to the Baker Institute and started working with Professor Andre Laguerche, who had an interest in cardio-oncology. And our group was really interested in trying to use the exercise medicine approaches that I'd used in other clinical populations in cancer patients. And our group is very focused on trying to intervene very early in the trajectory of the cancer patient. So when the patient is still receiving treatment or undergoing treatment, using exercise in a personalized way to try and prevent any cardiotoxicity and ultimately prevent heart failure in these individuals.
Well, that's super interesting. This is such an interesting area. Really look forward to hearing more from you on this. Scott, tell us a little bit about your background, how you developed your interests.
So I'm like the introduction said, I'm currently working at the Toronto General Hospital Research Institute. My story started I'll start my story a little earlier than Erin did. Back at the master's level, I was working clinically at the time at the Jewish General Hospital in Montreal, the Segal Cancer Center there. We were developing our oncology rehab program. And we noticed aberrant cardiovascular responses in our patients, irregular like heart rate responses, sweating pattern responses. And when it came time to putting my master's together, we tried to find a common thread for what might be helping to explain why we're seeing what we're seeing. And we thought of looking at the autonomic nervous system and exploring the impact of treatment on autonomic function. And then we quickly realized that the literature was kind of all over the place. There was a bunch of poorly controlled studies done to that point that didn't account for many established confounders of autonomic functions. So we did a pilot study looking to see if it was feasible to collect robust autonomic data in patients who were receiving up to 4 cycles of chemotherapy. From there, me and all of my other personalities. From there, we went to Edmonton, and I started my PhD in the behavioral medicine lab of Dr. Carrie Kernier, who's a Canada Research Chair in physical activity and cancer. My doctoral work focused on high-intensity interval training in testicular cancer survivors. Now, this group is not a typical cardio-oncology population, but they definitely have some increased cardiovascular disease risk due to the therapies that they're exposed to. Several recent studies have found that these individuals who receive cisplatin, although that drug has improved survival rates from, I believe, like around the 50th percentile up towards like the high 90th percentile. So has done wonders for the treatment of germ cell disease. The drug actually stays in its active form for 20 plus years post-therapy, presenting a chronic stimulus for endothelial cell dysfunction and premature atherosclerosis development. So the PhD work was really focused on understanding whether high-intensity interval training positively influenced cardiorespiratory fitness, markers of vascular structure and function, and as a carryover, markers of autonomic nervous system function. From there, I went to Memorial Sloan Kettering with Lee Jones and Jessica Scott in New York for my first postdoc. And there we looked at, we took a bit of a different tact in terms of the scope of projects that we did, but really focused on some larger data sets, some population level data sets, as well as doing some reviews, really sort of looking at the methodological and reporting rigor of exercise oncology trials to date. And then from there, second fellowship at the University of Toronto with Doctors Catherine Savison and Daniel Santamina, and their work obviously takes more of a prehab approach and a behavioral approach. So got some nice complementary training there.
So Erin, I would be curious how you would answer this question, since this is one that I've gotten over the years, and I think my answer has changed over time. But when you first explain to a colleague or a patient that you are a cardio-oncologist, the first question is, what is that? And then, or the alternative is that they would say, is that cancer in the heart? And so with that as a background, why or how did you see the exercise working group sort of expanding our knowledge or understanding or treatments of patients that have cardio-oncology problems?
Yeah, that's a great question, Dan. I guess, the more what we're really learning about the effects of cancer treatments, especially in the cardio-oncology field, is although the heart is a key player and can be severely impacted by treatment and associated lifestyle changes that occur with following treatment, it's not the only impact that we see. So we see the effects of treatment in the muscle, we see the effects of treatment in the blood vessels, the lungs, the circulation. And so we need to have strategies that can target multiple systems. And that's one of the key benefits of exercise, is that, there's lots of research going on to try and identify what it is about exercise that is beneficial in multiple chronic disease states. And we are really, it's an exciting time. We're starting to learn a lot about these benefits, but we don't fully understand it. And I think that the cardio-oncology setting is really the ideal place for exercise to be used as medicine to try and target these multi-system impacts of the treatment and the lifestyle and behaviour changes that occur with in many of our patients.
Yeah, that's a great answer. I'm gonna have to start incorporating some of that into my answer next time. But the other part is we really need to, as you've both really addressed this, that it's the whole picture. And probably the nidus for cardio-oncology, at least in my mind, was at least initially it came from cancer survivors, and the childhood cancer survivors that lived into adulthood. And basically when their cancer was treated and everything looked good after 5 years or whatever interval, they were told, you're cured from your cancer, go live your life. And, that's a wonderful thing to say. And I do think that it's truly tremendous that cancer therapy progressed to that level. But on the other hand, what we know about exercise in those patients is it's really awesome how much of an impact exercise could have had or will have in the future, because somebody will decrease their typical exercise tolerance after cancer therapy dramatically, and they'll never recover it. So they'll say they're running at 100% before they get chemotherapy or radiation or whatever treatments. Afterwards, even if they survive all of that, which hopefully they will, they're running at about 25-30%. And that's the way they're going to stay the rest of their life. And, that is a profound drop in activity. And, so I think the cancer survivors were really the sort of the nidus for me to really introduce exercise as a therapeutic option in these patients. And then, of course, you can relate that to people that are actively being treated for cancer now. And that clearly, you don't want people to have that drop in function from 100% to 30%, just because they're receiving cancer therapy. So I wonder what you guys think about that. I mean, do you think that is an important motivation or an important area that we need to focus on, or what do you think, Scott?
Yeah, it's a great observation, and what you're really tapping into has confounding effects, has knock-on effects, right? Because once the tolerance has been decreased, despite what we believe are the potentially achievable benefits of exercise, once that tolerance is increased, our capacity to deliver these interventions effectively in this patient group is also diminished. So not only is exercise and structured, properly tailored and prescribed exercise important to improving outcomes, it's also a critical factor in enabling the delivery of this intervention. So there has to be an early preconditioning to restore function. And then once that function has been restored, then you can get into the more advanced type of training that can really impact vessel remodeling and cardiac remodeling and things that we know will improve long-term outcomes. But if you don't intervene, then it becomes this negative cascade of deconditioning, sequela, further deconditioning, further comorbidities. So exercise not only is likely a great multi-system therapy to address this, it's also an important precursor to deliver to its own delivery. Do you know what I mean?
Yeah, no, it allows the patient to get, whatever the optimum therapy is without a, hopefully without a side effect. And, so both for Erin and Scott, what kind of research are you currently engaged in?
Yeah, our research at the moment is really focusing, as I sort of alluded to earlier, on this intervening early in the patient kind of journey. So we've got a couple of studies running where we're looking at really trying to deliver a targeted exercise intervention in patients who are receiving anthracyclines for early stage breast cancer. So we are using a periodized exercise approach to periodize their exercise training with their chemotherapy cycles. And we're following these patients over a 12-month period with sort of a step down in our exercise supervision over that 12 months. And that study is looking at whether we can prevent functional disability, which is exactly what you were just talking about, Dan, this trajectory, prevent the trajectory occurring of patients getting into trouble after their treatment and not regaining that capacity or the reserve to go on and lead a healthy and fulfilling life. And that study is actually wrapping up in the next few months. So we're very excited to analyze that data and get that out there, because I think it will be, it's a randomized controlled trial of over 100 women. So it'll be a big study and contribute to the literature really significantly either way. We're also, my research is kind of focusing more on the hematological cancers, which are very, haven't really received as much research focus with the sort of cardiotoxicity prevention angle. But we know these are a group that get hit extremely hard by chemotherapy, bed rest, and in particular, we're focusing on allogeneic stem cell transplant patients, which are some of the most severely or aggressively treated individuals. And we're, again, trying to tailor an exercise and physical activity intervention in this group to be delivered whilst they're going through their stem cell transplant, so whilst they're inpatient, and then following them for exercising them in the outpatient setting for 12 weeks. And again, looking at whether we can prevent functional disability. We have a very novel way of assessing cardiac function at the Baker Institute. We have one of the only cardiac research MRIs in Australia, and we have it set up so that we can actually image the heart during exercise. So that allows us to look with very high resolution at measures like cardiac reserve, so we can really try and tease out what the effects of our intervention has been on the central components, on cardiac function, and also learn a lot about how the heart is impacted by these treatments. And so it's very exciting.
Super. Yeah, that sounds really unique. And, I think that when you think about even a otherwise young, healthy patient who goes to get knee or hip surgery or some other orthopedic thing, and, they got to lay in bed for a week or two or longer, depending on what it is, their functional status just took a major hit, even if they were perfectly in condition. And, how in the orthopedic world, they've come up with strategies for early exercise. It's astounding. They'll get somebody up and exercising 12 hours after having their hip replaced. And you're like, wow, I didn't think that didn't seem like a good idea. But, on the other hand, early mobilization makes it just a massive difference. And then, so if you equate that to stem cell transplant, they, especially during that first 7 to 10 days, they're basically hanging out in the room, laying in bed, just kind of suffering through the known side effects of the medications they were given. So yeah, that would be a huge, very important area to investigate. So I'm glad you're doing it. And then your comment also about, the research in the world of cardio-oncology predominantly has been in breast cancer, which it's great because breast cancer is a common cancer, but there's a lot of other cancers besides breast cancer. And so I think expanding our knowledge base in these other areas is really a priority of ICOS. So Scott, tell us about what you're up to.
Yeah. First of all, I'm really excited to see those study findings, Erin. So looking forward to having those come out. And
as a little side note, I will say that, so Scott and Erin have, set up this working group and all of this. And he's got like this 50-page, 5-year, 10-year plan. So to ask Scott, what he's been up to, be prepared to buckle your seatbelt and get ready. So,
and perhaps pull up a pillow in case you need something to fight some inside.
I'm the succinct one, so
that's right.
a good yin and yang co-chair situation happening here. So we're perhaps expectedly we're taking we've got a couple balls in the air right now with our research. So we're doing some big cohort retrospective analysis from patients that have gone through the Toronto Rehab Institute, looking at whether or not combinations of cancer, cardiovascular disease, or just the presence of CVD risk factors differentially impact cardiac rehab compliance, the outcomes of cardiac rehab, and then whether long-term, we're going to link it with some provincial data that we've got here, and whether long-term it changes outcomes. The participation and the compliance changes outcomes in this population. We're also interested. We're just launching another pilot study that I'm leading, trying to profile patients a little bit better. If we look at most of the screening tools for cardiovascular risk screening in oncology, they're really largely focused on heart failure symptoms, right? Heart failure related or predicting heart failure related complications. But we know that those aren't necessarily the most prevalent forms of cardiac complications in oncology. And we're using tools that predominantly focus on the heart. So I'm just launching a protocol now where it's in ethics right now, where we're using cardiorespiratory fitness, autonomic function, vascular function, cardiac imaging, looking at some mitochondrial health markers, markers of endothelial function, to more comprehensively profile patients at baseline, looking at how these factors change by the end of therapy, and then using some machine learning to risk model patients for near-term and longer-term outcomes down the road. And then most excitingly, we're launching our Himalayas study this week. We're getting our first, we've launched our recruitment for the Himalayas trial. The Himalayas trial is a national randomized trial here in Canada, rolling out at 5 sites, Vancouver, Edmonton, Toronto, which is the coordinating site, Montreal, and Halifax. And really what we're getting at with this study is understanding whether young adults who have developed stage B, cancer-related stage B heart failure, respond well to a traditional cardiac rehab-based intervention. It includes a little high-intensity interval training, a little moderate-intensity exercise with co-pharmacologic and behavioral support. That's a short-term acute phase intervention over 6 months, and then we will provide longer-term pharmacologic and behavioral support up to 2 years post-therapy. That's in the primary RCT, and then for the secondary parallel RCT, we're testing the effects of basically a behavioral support intervention by itself to see whether or not there are any comparable impacts on cardiorespiratory fitness, markers of cardiovascular disease risk, and cardiac health.
Wow, man, these are some exciting things you guys are working on. Steve,
I
Yes.
just wanted to jump in with a related sort of treatment question. And my question is, how do you dose exercise with these patients? And I'm sure that's a massive question that has a lot of complexities, but it's something that I just keep thinking. I mean, with the drugs and medications, you can dose very carefully. So tell us a little bit about how that works with exercise.
It's actually a very astute question, and one that we don't know quite yet. We don't know the answer to quite yet. So what's happened is, to date, the majority, I'll have to speak in generalities about the exercise oncology literature, because there hasn't been a ton of cardio-oncology exercise research done to date. So in general, in the exercise oncology field, most interventions have focused on delivering guideline-based, so 150 minutes of moderate to vigorous, or 75 to 150 minutes of moderate to vigorous physical activity, aerobic exercise. There have been some resistance training studies, but right now they've tested this fairly generic prescription. And then a confounding factor is that when you look at the quality of reporting overall in our field, there's a lot of missing information that would be required to really calculate dose response relationships between interventions and the outcomes of interest. So one of the things we're doing is within the working group is to try and establish standards for exercise or cardio-oncology exercise and rehab reporting and data collection, so that we can actually start to get at understanding what the actual dose response relationships are between the different approaches to interventions that we could deliver and outcomes of interest that are specific to key patient populations.
Yeah, Erin, I don't know if you have a favorite approach to how to prescribe, specific exercise to an individual patient. I mean, I don't know if there's some general guide or tool that you use.
I guess we're sort of fortunate, both Scott and I, to work in institutions that have access to cardiopulmonary exercise testing, and we are able to individualize our exercise prescription for our patients based on their cardiopulmonary response to exercise. And so we look at determining different factors like their ventilatory thresholds. We look at their heart rate responses, and we can provide really precise exercise prescriptions. Now, that doesn't always work in cancer patients because the treatments can play havoc with their hemodynamic stability. So it's actually quite difficult to rely on heart rate to accurately prescribe exercise intensity as we would normally for many other chronic health conditions. So our group uses a combination of different things. If we're exercising people, we do a lot of cycle-based exercise, and that's because we measure our outcomes on a bike, and we do, it's all sort of geared towards our research. But that's also helpful because we can use watts to prescribe exercise intensity. But, in the field, using perceived exertion is probably the most commonly used approach, and that's sort of what's recommended in the guidelines. Again, is that a moderate intensity exercise prescription is an RPE of about 13, and a hard to vigorous is sort of the 15 to 16 RPE scale, and I think they work quite well if you've got a patient that understands the concept of what you're trying to. That understands the concept of the intensity, and that can be a little bit challenging for some individuals, but in general, it's the approach that we use. The other point that I would make is kind of what Scott was speaking about earlier, is that for some of these patients, especially the stem cell transplant guys and those who have been in bed rest or ICU and things like that, then it is really just prehab sort of focused exercise where you're trying to get them mobilizing, get them active, doing really functional type tasks to precondition them to be then able to start an actual structured exercise program. That's certainly an aspect of working with cancer patients at different stages of their journey.
Beautiful. So and this question will be to each of you, but we can start with Scott. Can you kind of give us a brief overview of what the current evidence is that exercise therapy may be helpful in cardio-oncology patients? Where do you see the current status?
Yeah. So I think, like I alluded to earlier, there isn't a ton of cardio-oncology specific research that's been done yet. And by that, I mean selectively targeting populations with known high CVD risk profiles, and then really tailoring interventions to address the specific mechanisms of injury and deficits within that population. Most of the evidence to date is within more heterogeneous patient populations, where they may all be individuals with, say, breast cancer or hematologic disease, but a mixed group, not just high-risk individuals with higher exposures to anthracyclines and thoracic rads and such. So if we're generalizing from that evidence base, certainly we know that there's robust evidence to say that exercise improves cardiorespiratory fitness. The perhaps not widely known implication there is that this outcome, cardiorespiratory fitness, seems to be a robust independent predictor of mortality in this population, and that's something that we need to focus on more as a primary intervention outcome. Beyond that, however, there have been very few studies to date that have specifically targeted other competing mechanisms of cardiovascular risk in a homogeneous patient population. And of the studies that have been done today, I would say those types of outcomes have been more secondary. So the studies haven't necessarily been properly powered to address the effects of the interventions on these outcomes. So while I think there's really exciting early evidence that exercise can improve vascular structure and function and autonomic reactivity, and certainly hormone and metabolic profiles, as well as perhaps blunting some of the adverse cardiac effects in these patients, we haven't had the large definitive trials done in this area yet, which isn't negative. It just indicates that we're early days in the field. There's a lot of really important work left to be done. Yeah.
No, that's a great summary. So, Erin, how do you see the current field? Because obviously, the two studies that you told us about that you're primarily doing, you're attempting to address specific questions. So that doesn't mean that your research is going to answer every question, but those are the ones that you kind of picked. Now, so where do you see the field at this moment?
Yeah, I think we've picked these sort of surrogate endpoints in our study, like Scott just mentioned, cardiorespiratory fitness, cardiac reserve, measures that we know that are related to long-term outcomes in other populations and have been shown in cancer patients as well to predict mortality. But we need to figure out if these interventions are going to have change long-term outcomes for our cancer patients. And I think that's really what I'd love to see. And, hope that through ICOS, through this working group, we'll have the opportunity to try and answer these bigger questions of that are going to require, large numbers of patients with, studies that are sort of using, consistency across outcome measures and interventions to be able to try and answer what's happening to long-term outcomes. I think even if we're looking at preclinical models, the evidence is not even super strong and still emerging in that respect as well, because it is so challenging to create an animal model where you can have a tumor, you can give them chemo, give them docs, and then get them to exercise. I think it's a lot. We're going to try and do that ourselves in Melbourne, but I think I'm not sure why it hasn't already been done, but I'm assuming it might be a bit challenging. But to even get those, models set up to try and answer it in the preclinical setting seems challenging. So, it's an exciting time, and I think we've got this is a great platform for us to try and answer these big questions together.
Yeah, I think that strength in numbers, no doubt, but the other part is that and I think the entire world of cardio-oncology is in this space. But when you are diagnosed with cancer, so let's say one of us was diagnosed with cancer, and you see your doctor and they say you're going to get ABC, it's going to take 1.5 to 2 years, to do, the chemo and radiation, surgery, whatever combination of things. And at the end of all that, maybe we'll give you good news. I mean, that's basically what happens, when a patient has a diagnosis of cancer. So your whole focus is on that. It's on cancer. And, to change your focus, not so much. Of course, we don't want to lose sight of treating the cancer. Actually, we want patients to be in better shape and better able to tolerate that really rigorous treatment. I mean, 1.5, 2 years worth of, various treatments is devastating. And so, it's one of those things where you have to kind of move your focus from not just the cancer, but, what's the collateral damage that's going to happen, and how can we minimize that? And certainly cardiac issues are the biggest collateral damage. So in one sense, you could say cardio-oncology is like, it's kind of like the ultimate support team. We want to make the, situation as good as possible so that this patient can then get through this very vigorous problem. And so, I think that, your own personal studies that you guys are doing are wonderful. And we really look forward to, not only finding out what your research does, but also, how you can pull the rest of us along to advance this space.
So before we jump off, I have another treatment-related question, and that is there any evidence that exercise during cancer therapies increases the efficacy of the therapy itself?
Great question. One of the first studies that I really got interested in was an animal model looking at exactly that. They had implanted tumors into mice and trained them. And I believe the intention of this study was to address early concerns as to whether or not exercise increased the growth rate of tumors. So not only did they find that there was no difference in the tumor mass externally, they found the accidental finding was that once they had administered doxorubicin, the tumors in the exercise animals shrunk more. And upon autopsy, they found that the vascularity of those tumors had improved. So when you think of tumor growth, there are, because it's erratic and irregular, there are large pockets of tumor bodies that are hypoxic. There's irregular blood vessel distribution throughout them. And when you get these hypoxic pockets of tumors, systemic therapies like chemotherapy can't actually reach those areas of the tumor as effectively. But via normalizing the tumor vasculature with exercise, a higher percentage or higher surface area of the tumor was actually exposed to the therapies and therefore decreased, shrunk better once those therapies were introduced. And I know Lee Jones is leading a fairly aggressive line of research in this field. I know there's some work done in Scandinavia as well that have looked at the cancer-related effects of exercise in normalizing tumor microenvironment, the tumor itself, as well as its microenvironment that could potentially arrest or mitigate the growth of these various diseases. And I know Alison Beetoff Warner from Sloan Kettering as well. I think she had data that there was a model that tested 4 different groups. One was exercise plus therapy. One was therapy only, one was exercise only, and one was control. And they found that there was a synergistic effect between the exercise and anti-cancer therapy group, where they had a greater reduction in tumor volume, whereas the exercise by itself and the chemotherapy by itself had a similar effect on reducing tumor growth rate over time. So I think there are some really compelling early wins in that area, and a lot of really important work left to do there as well.
Super.
Well, Scott and Erin, thank you both so much for giving us your time. This has been a really fascinating conversation. I think we could spend a couple more hours together, but we really appreciate your time and the research that you're doing and the encouragement to continue to press into these areas that are new and developing, but super helpful. So thank you both for being with us today.
Yeah, thank you both, Erin and Scott. We appreciate all your efforts, and we're excited to see what kind of developments you guys are leading.
Thank you so much for having us. We really appreciate the opportunity and all the support you've given us so far. This is tremendous.
Yeah, thanks a lot, guys.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.